Good morning. It's a pleasure to be speaking to this group. So my topic was musculoskeletal focus, but really within the broader area of musculoskeletal illnesses, the one that's of most relevance is low back pain, because low back pain is the disease process for which patients are much more likely to progress from acute pain to chronic pain, and much more likely to be associated with an opioid naive state progressing to a persistent opioid use state. So I have no disclosures. So I'm going to begin by reviewing some of the existing clinical practice guidelines. The first one is probably well known by many of the people in the room. It's the ACP guidelines. I'm going to highlight several of the points that were made in these guidelines. Number one, evidence was insufficient to determine effectiveness of opioids versus placebo in patients with acute or subacute low back pain. Next, given that most patients with acute or subacute low back pain improve over time regardless of treatment, clinicians and patients should select non-pharmacologic treatment with superficial heat, massage, acupuncture, or spinal manipulation. If pharmacologic treatment is desired, clinicians and patients should select NSAIDs or skeletal muscle relaxants. Again, opioids are not mentioned here. And then finally, with regard to side effects, moderate quality evidence shows that short-term use of opioids increased nausea, dizziness, constipation, vomiting, somnolence, and dry mouth compared with placebo. Moving on to another set of guidelines. These are the American College of Emergency Physician guidelines on critical issues in the prescribing of opioids for adult patients in the ED. They tackled low back pain as part of these guidelines. One question was, in the adult ED patient with acute low back pain, are prescriptions for opioids more effective during the acute phase than other medications? And really, they were not able to identify a lot of evidence to come to a definitive recommendation. With a level C recommendation, the guideline author said, for the patient being discharged from the ED with acute low back pain, the emergency physician should ascertain whether non-opioid analgesics and non-pharmacologic therapies will be adequate for initial pain management. And in fact, this is a theme that we see multiple times throughout various guidelines. Here, point number two, opioids should be reserved for more severe pain or pain refractory to other analgesics rather than routinely prescribed. And, I haven't been able to identify a whole bunch of evidence to support, or refute the statement. And this is one of the big evidence gaps that we can discuss a little bit later. And then finally, a recommendation that we see in multiple different settings with regard to opioids: use the lowest practical dose, a limited duration. Here they said 1 week, and the prescriber should consider the patient's risk of progression to opioid misuse disorder. Continuing, they had another question that this committee may find relevant. And so they asked, in the adult ED patient for whom an opioid prescription is considered appropriate for treatment of new onset acute pain, are short-acting Schedule II opioids more effective than short-acting Schedule III opioids? This is based on the 2012 scheduling. And here they had no level A recommendations, but there is some evidence to support the fact that for short-term relief of acute musculoskeletal pain, emergency physicians may prescribe short-acting opioids such as oxycodone or hydrocodone products while considering the benefits and risks for the individual patient. So here, the opioids that were perceived to be not as risky, although I guess the more modern definition may not recognize these as such, had comparable efficacy. So these are the various choosing wisely statements that were on topic. One from the North American Spine Society, they said, don't prescribe opioids for acute low back pain before a thorough evaluation, consideration of a trial of alternative medications and treatments, and discussion of the risks of opioid therapies. And from the American Academy of Physical Medicine and Rehab, don't prescribe opiates, they said, in acute disabling low back pain before evaluation and a trial of other alternatives is considered. So I think the very common theme that we're seeing among these various statements, and it's actually true internationally. A variety of international organizations have made recommendations as well, and consistently, what we see is the sense that opioids may have a role to play, but opioids should not be used as first-line therapy or second-line therapy. Let me review some of the data. This is a study that we did in my ED in the Bronx. This is a trial looking at combination therapy. So everybody got naproxen, and then some people got oxycodone in addition to the naproxen. Some people just got placebo in addition to the naproxen. So we enrolled ED patients, emergency department patients with acute non-radicular functionally impairing low back pain. All of them got a 10-day supply of naproxen plus the oxycodone acetaminophen combination. The control group was naproxen and placebo. These patients, we followed them at 7 days and 3 months, looking at functional outcomes and pain scores, and there was no difference between the groups. There's no difference among those who got naproxen plus oxycodone versus naproxen plus placebo. Of note, there were many more adverse medication events in the oxycodone group with a number needed to harm of 5. These medication events were mostly nuisance type symptoms, dizziness, drowsiness, but still an important factor to consider. One thing that we did notice in these data is that we actually identified a subgroup that might benefit from the Percocet, from the oxycodone combination. So we looked at the adherers, and so these medications were dosed PRN, so adherence is not quite the right word, but for patients who took oxycodone acetaminophen more consistently, they actually had a pain benefit at 7 days with a number needed to treat of 6. So, what this speaks to is, if we're trying to define a role for opioids, it seems that it's, they're not appropriate for everyone, but there are patients who may benefit. With regard to 3-month outcomes, there were no efficacy benefits among those patients who got opioids. And again, thinking about the transition from acute pain to chronic pain, there was no evidence that opioids could somehow mitigate that transition. Although granted a relatively small trial. But interestingly, opioids in this study were not associated with higher rates of functional impairment, were not associated with more frequent visits to the ED, and were not associated with an increased propensity for continued opioid use. Here's another study of looking at opioids versus nonsteroidals for acute low back pain. In this study, patients got either ketorolac, it's oral ketorolac, or a combination of codeine plus acetaminophen. These are emergency department patients with acute musculoskeletal pain, musculoskeletal low back pain. It was moderate or severe in intensity, and it was less than 72 hours. They enrolled 120 patients altogether. Patients in this study got either the combination of acetaminophen, codeine, and they got up to 6 doses of this in 24 hours, or the control group was oral ketorolac. And in this study, there was no difference in either pain or functional scores in the first 6 hours, and they continued to follow their patients for up to 1 week. And noticed no difference in pain or functionality between the groups, with substantially more adverse events in the codeine arm. There's a number needed to harm in this study of 3. Here's a study that combined a variety of musculoskeletal ailments, although the majority of these were patients with spinal pain or back or neck pain. So these are patients with ED patients with pain that was greater than 5 on the 1 to 10 scale, hyperacute, so less than 24 hours. This is comparing an oxycodone combination with a COX-2 inhibitor. Again, we see a similar thing: comparable rescue medication use at 60 minutes. In fact, the COX-2 inhibitor did slightly better with regard to VAS outcomes, and sedation and dizziness were worse in the oxycodone groups, again, with a number needed to harm of 3. And then finally, one more study that's probably of relevance, although this wasn't dealing with back pain. This was dealing with isolated musculoskeletal extremity pain. Again, an ED-based study where patients were randomized to one of 4 different arms. One of the arms was just ibuprofen plus acetaminophen, and the other 3 arms all had some opioid combined with acetaminophen. Looking at short-term outcomes, you're looking at outcomes up to several hours. There really were no substantial differences between the groups. The hydrocodone group might have been a bit inferior, but the ibuprofen acetaminophen combination was as efficacious as any of the others. So how does synthesize the data that's out there? I think these are sort of the general principles that I got out of this. So number one, among a general population of adults with acute musculoskeletal pain, including low back pain, oral opioids are not associated with improved short or longer term pain or functional outcomes, but are associated with more adverse medication effects. And I think that the literature is fairly clear on this point. This is a good rationale for recommending avoiding opioid use as first-line therapy, across a variety of musculoskeletal ailments. Number two, it is unknown whether oral opioids improve short or longer-term outcomes among patients with severe or functionally impairing low back pain who have failed to improve with non-pharmacologic therapies and non-opioid medications. And in fact, this is the clinical conundrum that I'll talk a little bit more about later. But it's fairly straightforward, I think, for clinicians to recommend either non-steroidal anti-inflammatory drugs as first-line therapy, to recommend supportive measures like heat or ice packs, to recommend various complementary therapies, including spinal manipulation. But for patients who haven't responded to these various first or second-line therapies, then what? And do oral opioids play a role? And how do we determine which opioid and when? So, I think this is the important issue for this committee to consider. Number three, it is unknown whether patients with acute musculoskeletal pain who are at higher risk of adverse outcomes with non-steroidals or skeletal muscle relaxants may benefit from opioids. So again, low back pain is highly prevalent. There are plenty of patients with low back pain who have concomitant gastrointestinal illness or chronic kidney disease. And so should opioids play a role among these patients? And in fact, should opioids move higher up on the list of recommended pharmacologic therapies? That's a question that needs to be answered. It's unknown because these patients are always excluded from the clinical trials. And then finally, this is a bit farther out and not all that much data on this, but among patients with acute musculoskeletal pain, some data suggests that there's no clinically important difference in efficacy among the different opioids. It is unclear, however, whether different opioids have greater risk of progression to opioid use disorder. And so if an opioid needs to be used, is there an opioid that's preferential? And again, there really is not a ton of clinical trial data. In fact, there's very little clinical trial data to weigh in on this question. So here's an illustrative vignette. And in fact, I was working in one of our emergency departments last night, and I saw a gentleman very similar to this guy. In the vignette, I put the story of a 47-year-old male with no medical history who presents with new onset, worsening, functionally impairing low back pain for 4 days. The patient that I saw last night happened to have a history of intermittent low back pain previously, but certainly was not chronic pain. This gentleman had been to the chiropractor and had taken appropriate doses of a non-steroidal. He's tried to remain active and has been applying heat. He says he can't bear the pain. So how do I treat this patient? Guidelines recommend that I offer him reassurance that it will improve. Great. Sometimes that helps. Often it doesn't. Stretching techniques and physical therapy may play a role, but not necessarily going to help the guy who's suffering right in front of me. And then when it comes to the choice of skeletal muscle relaxant, opioid, or nothing, there really is not much data out there to help me decide which of these therapies I should do. So for my sense, the research priority should focus on treatment of acute back pain. and treatment by treatment of acute back pain, I mean mitigating the acute pain, restoring functionality, and then preventing the transition to chronic pain. So looking at the treatment of acute back pain among patients with pain refractory to first and second line therapy. Should opioids play a role? Are opioids associated with worse outcomes than non-opioid pharmacological alternatives or rapid access to physical therapy? And is there a substantial difference among opioids at risk of progression to persistent use or opioid use disorder? And so now focusing in on various questions that were posed. In fact, the committee has done phenomenal work, and there's not much to add with regard to how to think about acute pain. I would just say that while treating acute pain is a very important goal, an equally important goal is preventing the progression to chronic pain. Back pain is certainly a model of disease where patients present with acute pain and over time develop chronic pain. And so even if opioids don't help that much with acute pain, they may have a benefit with regard to preventing the progression. That's a hypothesis. There's not a ton of data one way or the other to support or refute that statement. So what additional information, so what evidence is needed, trade-offs. So that there's, given the very large prevalence of low back pain and the very large societal costs, there really is a tremendous paucity of data. RCTs are needed to identify subgroups that may benefit from opioids. And by subgroups, I really mean the groups that I mentioned before. So patients who have failed first and second line therapy, and patients who can't tolerate first and second line therapy. So RCTs to identify these subgroups, and then I would say cohort studies to quantify the risk associated with specific opioids. Are codeine combinations better than oxycodone combinations, or better than hydrocodone combinations? Again, not a lot of data not a lot of high quality clinical trial data to support to weigh in on that. And something that's of interest to me in this question, the question of the risk associated with specific opioids, is the role of opioid-induced euphoria. And so there is some experimental data on this, but not that much. Does opioid-induced euphoria impact the transition from opioid naive to persistent opioid use? Can we use this variable, or is there some way to assess this variable to help us predict which opioids are preferable? How would you conduct studies for conditions where RCTs may be impractical or where resources are scarce? So not really an issue for low back pain. Low back pain is a highly prevalent condition. In fact, most musculoskeletal injuries are very highly prevalent conditions. Standard of care management does not require advanced diagnostic testing. Treatment does not require surgery or interventions. So RCTs, in fact, are very feasible. And I would, and also we are interested in these rare adverse opioid outcomes, this transition to opioid misuse disorder. These would need to be captured with multi-center cohort studies. Now talking about dissemination, real-world setting. So opioid dosing needs to reflect actual practice. And so what that means is, so there's often variable dosing. So patients are instructed to take 1 or 2 pills of a certain medication. Patients are often instructed to combine opioids with other medication. And in fact, opioids are often marketed in combination with other medications. So the opioid dosing scheme does need to reflect practice. Another big issue with incorporating practice guidelines into one's practice is limited access to care for very many of the non-pharmacologic therapies. Some patients can access the chiropractor or the physical therapist, but many places cannot. And so studies that are designed where opioid therapy is compared to having a physical therapist in the ED may be very useful for guiding pathways for clinicians to use. And final question here. So I guess what I said is, so opioids should not be used generally. I think, again, there is a fair amount of data to support that. Opioids are almost never indicated as first-line therapy. Clinical practice guidelines need to identify patients who are more likely to benefit. So that's it for my presentation. Thank you for the attention, and I guess we said we're taking questions at the end.